Hello everyone, this is Dr. Shreekant here. So today we have a case for a discussion. Again, this case is for the beginners to start with. So this is the case of L5-S1 paracentral disc prolapse in a very young patient who is just a 26-year-old male patient who was having symptoms since last 1 year. So every sort of the conservative management was tried. The patient come back after 1 year with severe symptoms, and here the disc prolapse was progressed compared to the last MRI. So here in a sagittal MRI you can see that there is a disc prolapse at L5-S1 with the sequestrated fragment on the right side. So if you go through the axial MRIs, again there is a right sided disc prolapse with the sequestrated fragment pushing the root laterally here. So in this particular case, my plan is to go interlaminar endoscopic discectomy. This patient particularly has wide interlaminar windows, so we are not going to do any bony decompression in this case. We are just going to do a small phlebotomy incision and we are going to finish our surgery. So this will be a uncut video of the entire surgery, and I'll explain all the steps involved in the endoscopic interlaminar discectomy at L5-S1. So the first surgical step in interlaminar surgery is identification of the landing point at the interlaminar window. So as you can see in the X-ray, this patient is having a wider interlaminar window at L5-S1. So we are not going to do any bony decompression in this particular patient. So in such cases where you are not intending to do any bony decompression and you are dealing with the L5-S1 wider interlaminar window, so the landing point should be in the middle of interlaminar window, as close to midline as possible. So here you identify the landmark, the incision landmark, with the help of any instrument whichever you want, and then you take the incision at the pre-identified point. So if you are using a discoscope, you can take 6mm incision. If you are using a stethoscope, you can use 8mm incision. So here you can take an incision in the skin, then you can go inside and take incision in the thoracolumbar fascia. Once the incision is taken, now you can insert a dilator and you can confirm the position of dilator in AP as well as in the lateral view. So this is the perfect position for the dilator here. Then you can insert the working sleeve with the bevel, opening up the bevel facing medially. And now I am just inserting the camera, and the next video will be the entire video will be about the endoscopic picture of the surgery. So this will be an uncut video, so you can identify all these steps. So the moment you are inside, you can see here there is the blood and the soft tissues lying in front of you. So the first step would be coagulate all the bleeding vessels from there with the help of radiofrequency ablator, and then you can remove the soft tissues in the interlaminar window. Remember, in this particular case we are not going to do any bony decompression. It is very important to coagulate all the bleeding vessels before plucking the soft tissues. So here I am just coagulating with the help of RF, which is a 4 MHz radiofrequency ablator here. So now this is the way you can remove the soft tissues from the interlaminar window. So you can already see there is some yellowish structure lying just beneath the soft tissues, which is nothing but the ligamentum fluum. So the yellowish structure lying in front of you is nothing but the ligamentum fluum. So at every step, whenever see any bleeding, coagulate those vessels. So there are some bleeding vessels at 5 o'clock position which are coming from the soft tissues. So coagulate those vessels and again remove those soft tissues in the interlaminar window here. So here identification of some landmarks are very important. So in this case we are going to identify the medial border of the inferior articular process, then the superior border of the inferior lamina and inferior border of the superior lamina. So as I am standing on the right side of the patient, so 3 o'clock is a cranial, then 9 o'clock is caudal, 6 o'clock is lateral, and 12 o'clock is a medial side. So this is the orientation of this particular surgeries. Now we are just trying to identify the landmarks here. So superiorly I am going to identify the superior lamina. You can see here I am already over the bone. This is nothing but the bone. So I have identified the superior lamina here. I am just removing more soft tissues from here. So whenever you see bleeding, remember this is very important point. Do not ignore this. Whenever you see any bleeder, try to coagulate it. If it takes 5 minutes, 10 minutes, nothing to worry about. But always try to coagulate the blood vessels the right away whenever you see it. So I'm just moving towards the inferior side. This is the fat which lies medially over the ligamentum fleum. So here I am just clearing the soft tissues from the internal lamina window and preparing it for the phlebotomy incision. So we have almost adequately identified all the landmarks. We have adequately removed the soft tissue from the internal lamina window. Now I am going to use the annular cutter, which is again very sharp instrument, and I am going to start the phlebotomy here. So remember, it is very important to keep the tip of the this sharp instrument always under vision. So what I am doing here, I am just using the rotatory moment to cut the ligamentum fleum layer by layer. At the same time, I have rotated the camera so that the tip of this instrument remains in my vision. I'm just using the tip of the working sleeve as a retractor. You can see here I'm just retracting the portion of the ligamentum fleum, or I would say I am stretching the ligamentum fleum, so the all the layers become stretched and you can have clear access of the phlebotomy here. So again same thing, I am just rotating the annular cutter layer by layer and cutting the ligamentum fleum here. You have to be very careful. Once you reach to the deeper layer, here you can see the color of the ligamentum fleum is changing. So deeper layer will be more pinkish or more pale, whereas the superficial layer will be more yellowish. So you can say I am already into the epidural space. You can see the epidural space here. So the moment you insert inside the epidural space, always change the direction of the annular cutter. So previously the direction of the annular cutter, the sharp tip of the annular cutter was lying medially. Now here, once I entered inside the epidural space, the sharp cutting edge is lying laterally. So in short, I am cutting the ligamentum fleum from medial to lateral aspect. So now I'm just cutting the ligamentum fleum layer by layer, stretching it and cutting it. This is stretching and cut it. Stretch it and cut it. So by doing so, you are just pulling the ligamentum fleum away from the ligament, away from the neurological structure. Now here I am using the tube sheath punch to cut the remaining ligamentum fleum here. So you can see here there are some bleeding epidural vessels. I am coagulating those vessels. Again, it is very important to coagulate all the bleeding vessels the moment you see it. So again I am going to use the tube sheath punch to remove the ligamentum fleum. Here your target is to reach to the lateral aspect of the traversing nerve root. So how much ligamentum fleum you need to see, you need to remove. So unless you see the lateral border of the traversing nerve root, remove the ligamentum fleum. So here you can see the structure which is lying immediately in front of me looks like a root, but again it is not confirmed. So try to remove ligamentum fleum all around so as the traversing nerve root comes completely in the vision. So bit by bit remove the ligamentum fleum, create this space lateral to the traversing nerve root. Again see the structure which is in front of me. I don't know whether it is the traversing nerve root or whether it is the disc. So do not just don't be in the hurry to just try to remove the disc fragment here. I would suggest you create this space, make the traversing nerve root visualize more clearly, identify its lateral border, and then try to remove it. Because even at this stage, I am not sure whether I am touching the ligamentum, touching the traversing nerve root here, or I am landing on the disc. So I'm just removing the tissues in the interlaminar space to identify the traversing nerve root. Now look at the structure lying in front of me. It might be a root or it might be a disc fragment as well. So the tip here is identify the lateral border of the traversing nerve root. Unless you see it, don't touch the structure lying in front of you. It might be a root as well, so don't poke it. So see, this happens, this usually happens. What you can see here is nothing but the plastic from the drape. So this happens, so it is always advisable before taking an incision, remove some part of the this plastic from the surgical site. So if you keep it inside unintentionally, it may cause infection. So this is some sort of common complications which happens during surgery. We have to take care of it. So here I can see I'm still not able to identify what is what. So I'm just creating some more space. Now I'm little bit happy about this scene here, because I can see the lateral border of the traversing nerve root. But again, I'm creating more space. So the root and the disc fragment are of same color here. So now I think you guys also can see the lateral border of the traversing nerve root. In a while, I'll just show you. So the root is little bit adherent to the underlying disc fragment here. I'll just show you the lateral border of the traversing nerve. That is the lateral border of the root. I'm just separating it. So again, don't be in a hurry. Try to separate the neurological structures and the disc fragment. So I'm just separating the structure. So that is nothing but the traversing nerve root which has mobilized because of the disc fragment underneath. So on the medial side, you can see the dura and the opposite races, fat coming from the opposite races. So here we are not going to go on the opposite side. Our intention is to do just discectomy and finish your surgery. So I'm just teasing out this disc fragment from underneath the root. So it is advisable to tease the disc fragment all around and then start removing it. So you can see here the disc fragment is slowly coming, slowly we are separating it from the underlying tissues. So it is slowly coming. So this will ensure the complete removal of the fragment. So if you tease it out, if you separate the disc fragment from all the surrounding adhesions, the chances of removing the disc fragment completely they'll more. So here I am just removing the disc fragment. I'm just pulling it. So in young patient, the disc fragment is like sticky type. So it is very unlikely that you will get the entire disc fragment in one go. So again, you have to remove such kind of disc fragments like bit by bit in piecemeal. So this is very young patients. I'm expecting the same. It won't be a single fragment. So it will be like a sticky multiple fragments. So here I am shrinking the fragment. The extruded fragment I am shrinking here so as to get access a clear vision. So now you can see there is a traversing nerve root medially, and you can still see there is a pressure over the root which has stinted dorsally. I'm just creating little bit more annulotomy here so as to get access to the underlying disc fragment. So as you can see, I can clearly see the lateral border of the traversing nerve root, and as I have removed the major part of the sequestrated fragment, now I can retract the traversing nerve root with the help of the working sleeve. Here you can see I have already detected, and now I can safely start the disc work because the traversing nerve root lies medial to the sleeve, so there are very little chances of having any injury. So now I can do my disc work here. You have two things to do. Number one, you have to remove the sequestrated fragment. Now you can see there is a huge fragment which is coming out. The one thing is removing the sequestrated fragment. At the same time, you have to handle the annular hump as well. And the third part is removing the free fragment from the disc space. So here I am going inside the disc and removing the free fragment from the disc space. See, at the end of the surgery, your root should be free. So for that, you have to remove the sequestrated fragment, you have to remove the annular hump. At the same time, you have to remove the disc fragment, free fragment from the disc to prevent the recurrence of the symptoms. In young patient, the disc is very hydrated. So if you use radio frequency ablator, you can easily shrink those disc fragments. So here I'm just creating a little bit more space caudally. Again, as I said, addressing the annular hump is very important here. So what I'm doing, I'm just removing the lower part of the annulus near the lower end plate here. As the fragment was caudally migrated, there are the chances that there might be a fragment caudally below the root. So that's why I removed more phlegm from the lateral recess caudally. So yes, there is a fragment. So here the next important step is to remove the free fragment from the disc space. So I'm just exploring the disc space for the free fragments. As already told, in young patient the disc material is very sticky, so it will take a lot of effort to remove the free fragment from the disc space here. Better you can shrink with the help of radio frequency ablator as well. So here I am addressing the hardened annulus near the superior end plate. You can see here I am using the cutter to remove this hardened annulus. So it's very important to remove this part of the annulus because sometimes it can irritate the traversing nerve root. Even after surgery, patient will have complaints of persistent leg pain, or sometimes the recurrence of pain also be there. So carefully address this sort of hard hump. If it is a soft, you may not have to touch it, but if you feel it is a hard hump, then try to remove it. And one important thing while removing this hardened annulus, be careful about the retraction of traversing nerve here. So intermittently relieve the pressure on the traversing nerve, otherwise the patient will have paresthesias. So we are done here. So you can see the traversing nerve root is completely decompressed. I can retract the traversing nerve root very easily here. The underlying hardened annulus has been removed. So there doesn't look like any free fragment here. Thing sometimes what you get, there are some epidural vessels which are adherent to the root, and you can see here the mobility of the root has been hampered because of that particular small vessel. So I'm not able to retract the lower part of the root medially. So I'm just going to remove the phlegm, little bit more phlegm, and try to cut that vessel so as to get mobile root. This is not necessary actually, but see, whenever you see it, then you get tempted to remove that part. So here I am just want to detach the traversing nerve root for that vessel, and it will be free. It will take your 5 to 10 minutes more. Ideally speaking, we have finished our surgery, nothing to do here. just because I saw some sort of less mobility, so I'm just doing it. You can see here that is the vessel. This is the vessel which is adherent, not adherent, but it is supplying and is going to the lateral recess. So obviously the mobility of the root is hampered here. So we'll just cut that vessel and our surgery will be over. So now I'm using the cutter to cut that particular vessel here. It's a normal epidural vessel. So now I can retract the traversing root medially. You can see the significant difference. The moment I cut that small vessel, I can easily retract the traversing root more medially. So we are done here. Now everything is free. The traversing root is mobilized medially very nicely. There are no disc fragment inside. This is just a final exploration. So we are done. You can see free and mobile traversing nerve root. I just want to show you the amount of phlebotomy incision here. So the root is free. I don't want to go to the opposite side. I'm just exploring the axilla to see whether there is any disc fragment is there or not. Or sometimes you may get an annular hump there, so it is always better to explore the axilla. And you can do it in L5-S1 because in L5-S1 you get a larger space, but in L4 L5 try to avoid this maneuver because you get a less space, and the over retraction of the dura or the traversing root may cause post-operative symptoms. So here I'm just taking liberty of the larger space and I'm just exploring the axilla. Now this is the sort of final survey. Everything looks free here. So I could have easily saved around 5 to 10 minutes in this surgery. But as this is for the demonstration purpose, I have shown detailed things here. So this is the root which is free. You can see the congestion of the root. I can easily retract the root. Now you can see I am withdrawing and everything is literally falling back. So all the soft tissues and muscle, they are falling back. So the incision is not more than 6 to 7 millimeter in this case. So we have finished our surgery. This is the kind of surgery every beginner should start. So one thing I just wanted to show you again here. See the size of the phlebotomy incision here. So you can see here I am now going to use the tip of the instrument. This is nothing but the cutter, tip of the cutter, and in open position it will be not more than around 4 to 5 millimeters. So you can see here our phlebotomy incision was not greater than 5 millimeter. This was the end of surgery. Thank you very much.